Hi, my name is Dr. Bonnie Key from the University of Pennsylvania. I'm a cardiologist and I direct a research program in cardio-oncology. And I'm here with the investigators of the PRADA study, Dr. Omland, Dr. Gulati, and Dr. Heck. And we're here to discuss their exciting study and as well as their exciting results. So, Dr. Gulati, why don't you tell us some of the background in terms of why you did this study, why you felt it was important?
Well, breast cancer is one of the most common cancer among women worldwide, and the contemporary treatment has led to improved survival. Unfortunately, one of the major concern of some of the side effects is the cardiotoxicity. And as the survival has prolonged, of course, the cardiotoxicity has become a more and more concerned thing that the cardiologists see. There are some studies suggesting that some heart failure medication, as candesartan or as ACE inhibitors or beta blockers, may prevent this cardiotoxicity. But most of the studies are done in a heterogeneous population. So we wanted to see if in early breast cancer treatment, the cardiotoxicity could be prevented by the use of candesartan or metoprolol.
Certainly a very important clinical question that we're facing in the care of our everyday patients. And Dr. Omland, can you tell us a little bit about the study design?
Yeah, so this was a placebo-controlled randomized double-blind trial, and we wanted to test two different drugs, a beta blocker and an angiotensin inhibitor, and therefore we used what is called a 2x2 factorial design, and that means that 25% of the patients would receive placebo, 25% of the patients would receive the combination, both therapies, and then 25% would receive metoprolol and 25% would receive candesartan alone.
And certainly we all know that in terms of clinical trial design, this is really the gold standard. So very well executed and very well designed. Dr. Heck, do you want to tell us a little bit about the results?
Yeah, so we found that the patients who did not receive candesartan, they had a fall of almost 3% in their ejection fraction, whereas the patient who did receive candesartan had a fall of less than 1%. There was no difference between the two groups when you compared with metoprolol versus no metoprolol.
And again, these changes in ejection fraction or cardiac function that you assessed were via cardiac MRI, which
Yes.
I know that you quantitated, which is really, again, the gold standard in terms of how we are defining cardiac function in cardiology today. And Dr. Gulati, do you want to summarize what you feel are the clinical implications for care today and how it impacts the field of cardio-oncology?
So the fall that we prevented was modest, but this is the short time follow-up that we had because it was the end evaluation was done just after the anti-cancer treatment. So a follow-up study is of course necessary to see how the terms and how all this affects in the future. But there are observational studies that show that early decrement in the left ventricular ejection fraction may be an associated risk factor for cardiac failure later on.
I also completely agree that these are very important and intriguing findings, and the long-term follow-up will also be critical in terms of determining what the effects of these medications are. And I wanted to congratulate you all on a very well-executed and well-done study. Thank you.
Thank you.
Thank you.